Welcome back to Not So Complicated, and today we are talking about heart blocks and everything you need to know on heart blocks. We will first review normal conduction pathway and corresponding ECG findings, how to read ECG findings like a just summary or recap, and then we will cover overview and types of them, and each type will be debunked into details including pathophysiology and ECG findings and also mnemonics and also the management pathway, right? So let's begin without further delay. So this is the normal pathway here. This is the segment of ECG finding here. So we all know there is P wave reflecting atrial depolarization, that is activation phase, and QRS wave, a complex reflecting ventricular depolarization, which is also activation. But in this case there is atrial repolarization also happening, but that is masked by the voltage of QRS complex, right? So the T wave here, it represents the ventricular repolarization or recovery phase. So what actually happens in this conduction pathway right here correspondingly is that the sinoatrial node depolarizes at the first. It depolarizes, right? So the impulse arrives at AV node. This is AV node. Impulse arrives at AV node via three different internodal pathways, right? So one of this pathway gives a branch here, which is also called Bachmann's nodule or bundle. You have to remember that. And these three internodal pathways converge before entering into atrioventricular node, right? So there is a fascia here that leads to physiological conduction delay. So after coming to the AV node, the impulse travels to the bundle of His in interventricular septum right here, interventricular septum, and then it will immediately get branched into two different things, that is left bundle branch and then right bundle branch right here. So then left bundle branch will again get divided into posterior fascia and then anterior fascia, right? So that is how the conduction occurs in normal cases, right? So and then these bundle branches will form Purkinje fibers over the ventricular walls, right? So that is how normal conduction pathway happens. So let's just begin. How do we actually read ECG? You might know about that, but we are also trying to get a detailed guide to read ECG as soon as possible. So you stay tuned until that happens, right? So we talked about it. The P wave here indicates atrial depolarization, right? First we will talk about wave, and then this QRS complex indicates ventricular depolarization, and then this T wave indicates ventricular repolarization. There can happen a U wave. A U wave can be present sometimes, right? Not always, but sometimes. Why that happens is because sometimes papillary muscle shows electrical activity, right? So in that cases U wave can appear. So you cannot get confused over that, right? So let's talk about segments first. Here there is PR segment, right? Here it is PR segment. So what does PR segment actually indicates is that like AV nodal electrical silence here. There is nothing here, right? No waves here. So PR segment usually indicates AV nodal electrical segment, and this is ST segment. ST segment is very important in distinguishing ST segment elevation MI and non-ST segment elevation MI, right? There are reasons why ST segment elevation occurs. So this actually indicates that there is complete ventricular depolarization, yet no repolarization has yet begun. So complete ventricular depolarization, but repolarization has not yet begun. That is how ST segment indicates, right? So let's talk about interval first. So interval is very important for us in these heart blocks. You have to remember intervals at any cost, especially PR interval. What does PR interval indicate? So PR interval is P wave plus PR segment. P wave plus PR segment, right? So what does it indicate? It is a duration in which SA node, like this SA node, generates impulse, then depolarizes this atria, then transmits up to AV node just before ventricular depolarization begins. So what does PR interval indicates? Like the impulse has begun in SA node, right? The duration. way in which SA node generates impulse, then it depolarizes this atrium, then it transmits up to AV node, but the impulse has not yet depolarized these ventricle regions. That is what PR interval means, and the normal value is less than 200 milliseconds or 0.2 seconds. We will talk how these boxes are counted to form the interval, the seconds, right? We will talk about that. And then the other interval here is QRS interval, and then QRS interval we don't actually consider that, but let me talk about it. So it is just the duration of QRS depolarization. There is QT interval. This is very high yield. This is what is important for us, right? So QT interval, it is the duration of for ventricular depolarization plus ventricular repolarization, right? The ventricular depolarization has begun in this area, and then repolarization is completely finished in this area. So QT interval indicates duration for ventricular depolarization plus ventricular repolarization, that is systole plus diastole, right? So that is QT interval. Now you know about how the waves and intervals and segments mean what things, right? So normally this happens, and RR interval, this is important to determine the heart rate of any ECG findings, right? So let's talk about these boxes right here. So a single piece of ECG actually has 300 large boxes. Let me change the thickness of this. 300 large boxes are there in a single piece of ECG, right? And the ECG moves with 25 millimeter per second speed. Right here you can see this paper moves with 25 millimeter per second, and then these 300 boxes are there. This indicate 1 minute. 300 large boxes. What are large boxes? This right here is a large box, right? So 300 boxes are there indicating 1 minute or 60 seconds, right? So one large box means 60 by 300 seconds, which is how much? This is 0.2 seconds, right? Which is 200 milliseconds, we can say 0.2 second or 200 milliseconds. So one large box actually indicates 0.2 seconds or 200 milliseconds. So PR interval normally happens in this one large box, but if there is PR interval delay, like PR delay, prolongation of PR interval, then it can happen more than 200 to 240 to 260 or 360. So that is what about heart block. That is what is heart block. And each beat has each large box has 5 small boxes, right? So you divide this 0.2 seconds by 5, so you get 0.04 seconds. So each small box, this small box indicates 0.04 seconds of ECG, right? So that is just the review for you. So you just have to remember what is the normal range of PR interval. It is less than 200 milliseconds. Just remember that for now. Let's begin. So what is heart block? Heart block is the disruption in electrical conduction of the heart, slowing or blocking impulses from the SA node to the ventricles. This is heart block. The impulses are getting blocked, not the heart. The impulses in the heart are getting blocked. So that impulse that arises from SA node is not getting into the final pathway where it should have been reached, right? So that is what heart block is. So they are classified by severity: first degree, second degree, and third degree. So second degree has two types. One is Mobitz Type I, we also call Winkeback's, and then Mobitz Type II, right? So we will talk about them, each of them. So each affects the AV node or below, altering the PR interval. So PR interval is maximally altered, and also QRS interval, PQRS relationship on the ECG. All of them has abnormal findings. So that is how we classify. Let's begin with first degree heart block. So what it is actually? Definition is that like delayed conduction through the AV node. There is like physiological delayed conduction in the AV node. I have talked about it due to fascia, right? But if it is pathological, that leads to first degree heart block, and that all impulses reach ventricles. But delayed. All impulses reach ventricles, but in a delayed manner. You have to remember that. So it is actually benign, and there are no any treatment that is done immediately if it does not have any chance to like get into convert into the more severe degree of heart, right? So the pathophysiology of this heart block is that there is prolonged AV node refractory period. We have talked about it. Here, there is a refractory period that we have talked in the nodal fascia region. There is delay, right? That is refractory period, but that is prolonged in this case. That is how first degree heart block occurs. So, slowed atrial to ventricular conduction happens, right? So, it is very common in what cases? It is very common in, sorry, it is very common in increased vagal tone, fibrosis, and also in ischemia. So the key findings is that it is benign and there are no dropped beats. What do you mean by dropped beats? Dropped beats are like the heart is beating, then beating, then beating, then it drops a beat, then again beating, beating in the same preceding manner. That is what the heart drop is. We'll talk about that in detail. So let's talk, let's debunk this ECG findings right here. What is normal PR interval? Normal PR interval was this one large box, which meant 200 milliseconds at maximum, right? But there is 2.5 box here. So the seconds increased to 360 milliseconds. The PR interval is maximally increased, delayed in this case, right? So there is PR almost 360 milliseconds. One P wave per QRS complex is there, and also PR interval of 360 milliseconds can be found in first degree heart block. So the mnemonics here, this is a poem. If R is far from P, then you have a first degree. That is how you remember. If R is far from P, then you have a first degree. That is a lot far, right? So there are also no dropped beats to remember. There is dropped beats in second degree. So that is how we remember here. So let's talk about Mobitz Type I or Wenckebach's heart block, right? So the definition is it is progressive AV node delay until a ventricular beat is dropped. In this case, a beat is dropped like this. As I have said, a beat is dropped in this region, right? So before dropping, what actually happens is, we'll talk about it later. First, talk about pathophysiology. There is incremental AV node fatigue that leads to lengthening of PR interval. PR interval is increased in this case too, but not until 360. That the maximum is 320 milliseconds in this case, right? So 260, 280, 320. But what does it mean here? Like they are increasing rhythmically, right? They are increasing rhythmically. Again 260, 280, 320. Rhythmically. There, the heart dropped a beat. So before dropping the beat, what actually happens? Dropping a beat. What do you mean by dropping a beat? How do you see that it has dropped a beat? You see there will be no QRS complex. There is no QRS complex like this here, right? These are different leads. You have to read about different limb leads, augmented leads, chest leads to find out which lead it actually is in. So we will talk about that in our ECG video that I have talked earlier. So stay tuned for that. Again, just a reminder. So there will be increase in PR interval until the heart drops a bit. Then again, the cycle will continue with the previous rate of increase in PR interval, right? So this is cyclical. There shows a cyclical pattern. Some can show 4:3 pattern, 3:2 P to QRS ratio. There can happen, right? So it means that there are 4 P waves to 3 QRS waves. That is 1 beat is dropped, right? Then 3:2, that is 3, like 260, 280, 320. There are 3 P waves, then a QRS beat is dropped. 3:2. 1 QRS beat is dropped. So it is also usually benign, right? So the mnemonics before that, let's talk about the notes. So this ECG finding is actually straight from the Hampton's book, Hampton's Guide for ECG, right? So that is a reference. You can look at that book. So progressive lengthening of PR interval one non-conducted P wave. Next conducted P bit has a shorter PR interval than preceding conducted bit. Then as with any other rhythm, a P wave may only show itself as a distortion of a T wave. You have to remember this all. So the mnemonics is when she winks, that is winkies, when she winks, my heart drops a bit, right? That is the mnemonics. So there is a pattern. The heart drops a bit only when she winks, right? You can remember, like the love of your life is coming towards you, but she or he doesn't know that you are in love with them, right? So the more steps they come closer to you, the more is your heartbeat. That is, the more the PR interval increases until when she winks, your heart drops a bit. That is how you remember. There is a difference with type 2 and type 1. There is a rhythmic here, there is rhythmicity here, right? So in type 2 Mobitz, what actually happens is that there is will be intermittent AV block without PR prolongation. There is no PR prolongation, and then there are random drop bits. So pathophysiology of this is that it blocks, like there will be block below AV node, his Perkins system, and then there will be fixed PR and random QRS drops. So that is like the difference is just like that. There will be increased PR interval in type 1, but there will be there will be no PR prolongation, that there will be fixed PR, and then there are sudden drop beats in type 2, but there are rhythmic drop beats in type 1. That is the difference. So the thing here is risk of progression to complete the block, that is third degree block, right? So if some P's don't get through, then you have Mobitz II. That is how you remember. If some P's don't get through, then you have Mobitz II. That is how you remember. Here you can see the PR interval of the conducted bits are constant right here. They are constant, right? And then one P wave is not followed by a QRS complex here. There is no QRS complex like this here. That is the ECG finding right here. Okay, let's talk about third degree heart block. This is the most severe form of heart block. There will be no conduction between atria and ventricles. There will be no conductions. They occur independently. They do independent things. Independent P and QRS rhythms. So you might have a confusion that if there is no traveling of impulse from atrium to ventricle, how can there be QRS rhythm independently? What actually happens is that the impulses are generated physiologically by all these four pathways, by SA node, by these nodal blocks, nodal like bundles, and then AV node, this bundle of His, then Purkinje fibers. Impulses are created by all of these fibers, but SA node is predominant. That is how the other pathways are normally in suppressed state, right? But if there is no transmission of impulse from this region to the AV block, what actually happens is that this suppressed AV node will start conducting. The suppressed bundle of His and Purkinje fibers will start conducting their one beat. That is how there is no any relationship or dependency between P wave and QRS rhythms in third degree heart block. That is how it happens. So the pathophysiology is there will be complete AV node or His Purkinje failure, atria paced by SA node, ventricles by escape rhythm, that is junctional or ventricular. So they are normally caused by severe ischemia and Lyme disease. This is very high yield. You have to remember this. Lyme disease presents with third degree heart block if presented late, and then congenital defects. The key is that there will be hemodynamic instability. Obviously, there can be. The notes are P wave rate is 90 beats per minute. No relationship between P waves and QRS complex. They can happen randomly here, like this. There is no P wave here. Small P wave, there is a large P wave, there is a PR interval prolonged, there is no PR interval at all, right? That is how this is very, very haphazard. And QRS complex rate is 36 beats per minute. You can see P wave rate is 90 beats per minute. QRS complex rate is 36 beats per minute. No synchrony is there, right? Abnormally shaped QRS complexes because of abnormal speed of depolarization from the ventricular focus, obviously. So the mnemonics is, if P and Q don't agree, then you have a third degree. If P and Q don't agree, then you have a third degree. That is how you remember. So the management pathway is in first degree, what actually we do is observe, only observe. And if it has a high probability of turning into the second degree, then we treat the cause. And in second degree, there are Mobitz I and Mobitz II. In asymptomatic cases, we observe only. In symptomatic cases, we give atropine and also pacemaker if it is irreversible. And in Mobitz Type II, pacemakers is given. And in acute cases, we give atropine or pacing. Third degree, the same is there, pacemaker. And in acute cases, atropine or isoproterenol and pacing. So that is how we complete our heart blocks. I hope this is very helpful to you. And if you have any confusions, you can comment it down and I will try to reply you as soon as possible. Please subscribe for more clinical pulse for this. And thank you for staying with me.